consultant from Gastroenterologist Richmond Gastroenterology Center, okay, who will be sharing some of the latest insight and best practices in gastrointestinal issues found on the screening H.Pylori. Dr. John, over to you.
So today's agenda, we're going to talk about liver ultrasound. What are the characteristics of lesion you commonly see during health screening? And then we'll deep dive into other common GI screening tests such as H.Pylori and then GastroClear. And for the second half, as it is related to GastroClear, I'll talk a little bit about gastrointestinal metaplasia. What is the implication for our patients? Liver lesions on ultrasound usually we would is always get characterized into different categories. For example, the location, is it near a blood vessel? Is it on the left lobe or right lobe? The sizes, the radiology often describe it into the 3 dimensions. Shape, whether it's round, oval, or irregular. Margins, whether it's well-defined capsule, lobulated, or there's a very difficult to see or ill-defined margin. Echogenicity is one of those things where it compares to the liver echogenicity in the background. For example, a hypoechoic, we know is brighter than the usual liver parenchyma. Hypoechoic means a bit darker. Isoechoic is the same sort of gradient in terms of the echogenicity, or whether it's mixed. Sometimes the radiologist will report the internal architecture, for example, whether it's homogeneous, whether there are cysts inside, whether it contains blood vessels. In terms of shape, around a liver lesion usually benign, especially if it's smooth and well circumscribed. Oval, because of the irregularity, it's not circular. Sometimes it could be possible related to the malignant potential. In terms of the irregular liver lesion, usually we will say this is more likely and more suspicious for malignant lesions. In terms of margin, you can see you can just see the faint margin. So I would say this is probably not so well defined. And this one you can see some septum cystic structure, and the margin is not so well defined. So usually a well defined usually suggests a very benign kind of prognosis. Those with ill-defined lobulated can be seen in benign, but most of the time you need to consider malignant potential with the liver lesion. Echogenicity. So what I discussed before, a little round, bright spots that is brighter than the background liver parenchyma. This is considered as hyperechoic. This will be hypoechoic. It seems to be darker than the liver parenchyma. This is isoechoic, where it looks just faintly. You can see the lesion with a little of a faint demarcation. This is isoechoic. Anechoic will be completely black with no internal echoes. Usually we associate this with cyst or fluid-filled lesion. Most of the time, these cysts, liver cysts, are benign, but you have to watch out for certain radiological features. For example, whether they are septations, whether they are debris, whether there are any nodules on the cystic wall, or elements suggest that there could be a small solid component. Irregular walls is also one of those things, or increased echogenicity of certain parts of the cystic wall is also a red flag, and they should be referred. And this is a cyst with multiple septum. So these ones will need to be referred for further scans or CT scan. Typically, hemangio is probably one of the commonest lesions we see on a routine ultrasound screening. It's typically hyperechoic, well-defined margin. In cases where or the radiological reports suggest a heterogeneous uptake, cystic components, and these ones you should be a bit more concerned. For example, this one you can see the borders are a bit irregular with some cystic anechoic components inside, these should be referred for further scans such as CT or MRI. One of the important things, of course, is that when you see a hemangioma, radiological report suggests it's hemangioma, you could monitor with ultrasound over time, so every 6 months, for example. And if the lesion stays pretty static, you know this is a benign lesion. Other features that will differentiate this being a more malignant, more concerning lesion is that it has irregular border, heterogeneous lesion. It's not a uniform, consistent hyperechoic lesion. It has cyst inside, or it has marked heterogeneity inside the lesion. So different cysts behaves differently. Of course, cystic tumors we split into simple cysts, which is usually less than 3 centimeter, and it's simple. There's no septations, no flaps inside the cyst. Polycystic liver disease, this is rather uncommon, and it's usually related to autosomal dominant polycystic kidney disease genetic mutation. These they don't have long-term issues with their liver prognosis unless some cysts are over a certain size and it obstructs or blocks your biliary or vascular structures. Finally, there's something called biliary cystic adenoma. It's usually benign, but has a high risk of malignant potential. So this will be the ones that you need to watch out for and differentiate between the simple cyst. So biliary cystic adenoma, usually not very common. It's biliary in origin, but it has 20 to 30% malignant potential. The sizes are quite variable, but you'll notice that there's the symptoms, there are multiple symptoms, and there's abnormality or irregular thickness of the septa. These kind of things are generally concerning, so you will need to refer for further scans and ultrasound or CT or MRI to further delineate. Generally speaking, because of the malignant potential, you should have a low threshold to send to the surgeons for resection. Focal nodular hyperplasia. It is a hyperplastic reaction related to the arterial malformation. It's probably the second or the third most common liver lesion. Mainly occur in female, and it is not related to oral contraceptive, but it is related to your the female hormone. So therefore, the peak age is usually 30 to 50s. After menopause, the lesion can regress. Not commonly, it would be a multifocal lesion. So what does it look like? It usually looks isoechoic to the normal liver parenchyma. Sometimes can be hyper, sometimes can be hypoechoic. It doesn't have a true capsule, but you can kind of tell that as it compresses the surrounding structure that this is a well-defined margin. The color Doppler can also give you some suggestion. This is a focal nodular hyperplasia, FNH. Hepatic adenoma. This is one of those lesions you need to differentiate between FNH and also hepatocellular carcinoma, because this is also hyperechoic. So it can be hyper or hypoechoic. Hepatic adenoma, like any kind of adenoma you see in the gastrointestinal tract, it can grow and it can have some malignant potential. Now, hepatic adenoma does increase in size due to oral contraceptive pills in females. It may get bigger, and the bigger it is, the higher the malignant potential. So the important thing to do here is you have to do CT scan or MRI to further delineate. HCC, not so common, but it is, of course, in your patients who has liver cirrhosis or chronic liver disease, you'll need to be more cognizant. And any patients with liver cirrhosis, you'll need to do 6-monthly ultrasound to monitor. Hepatocellular carcinoma, HCC, is also a great mimic. It can be hypoechoic, hyperechoic, but it does not grow in patients with no cirrhosis. Also, only in cirrhotics would you get increased risk of HCC. Other than that, would be hepatitis B carriers who are over a certain age. For example, Asian male more than 50, Asian female more than, Asian male more than 40, Asian female more than 50. Now, you will have arterial vascularity on ultrasound Doppler. Sometimes you can get a mosaic pattern where some spots are brighter, some spots are darker. Now, based on these lesions, when you see the patients at health screening, you need to consider several things. For example, the size. Is it big? Is the margin well-defined margin, or is it irregular? Does it have any irregular margin with increased echogenicity in certain parts of the liver, the lesion? Whether it's hyperechoic or hypoechoic, whether there's heterogeneous internal features, whether there's blood vessels inside. Your tumor markers, which you also taken at the time of health screening, can also help you guide to see whether this is something urgent that need to be seen by a specialist. Always consider if there's a liver lesion and the person has chronic liver disease or liver cirrhosis, you should have a very low threshold to refer to a specialist. Otherwise, for example, if you see a cyst and anechoic lesion, fluid fill, it's simple. Usually you don't need to worry. Should you need to monitor or survey, interval ultrasound will be reasonable every 3 to 6 months, provided all the other red flags are not present. So H.Pylori antibody is one of the common tests that primary care will do in primary care to do health screening because it's simple. You don't need to do any preparation such that you need to do for urea breath test. However, you need to expect that there's a degree 5 to 15% of false negative rate and 10 to 30% of false positive rate. So what does this antibody mean? It means when it's positive, it doesn't mean there's an active infection. Someone could be treated already, and 2 or 3 years later, when you check the H.Pylori IgG, it could still be positive. Completely negative result doesn't rule out because it has a very low specificity as well. So if needed, I would recommend to do health screening for accuracy of the result to do a urea breath test or stool antigen test. I think the stool antigen test is sent out to SGH. When someone has a positive H. pylori antibody, you always need to check the patient's symptoms. Family history of H. pylori, family history of stomach cancers. In a setting where you know, okay, this person has symptoms and your antibody is negative, you should still refer for gastroscopy because particularly if their age is more than 40, 45, because premalignant gastric lesions are very difficult to diagnose and they can manifest as anyone with indigestion or reflux. So important thing with the urea breath test, so this is my go-to test in clinic, is to do a urea breath test just to see if someone has active H. pylori infection. But remember, you gotta make sure the person takes no antibiotics for 4 weeks, no PPI for 2 weeks, and no antacid or prokinetics for two days. So let's deep dive into H. pylori as infection. The prevalence in Singapore is about 25 to 30%. Latest studies suggest it's slightly lower because of the improvement in urbanization of our population. Remember, H. pylori is a class 1 carcinogen, so it increases your risk of gastric cancer or mucosal-associated lymphoid tissue lymphoma. By eradicating it, you actually reduce the risk of incidence of gastric cancer by 40 to 60% over the next 25 years. The numbers needed to treat to reduce gastric cancer is 72. It is transmitted through oral fecal routes. So sometimes in a household, if one person is diagnosed with H. pylori, I always recommend the family members, even though they are asymptomatic, to check through UBT to see if they have active HP infection. Remember, first line of therapy for H.Pylori is always triple therapy. So your PPI plus amoxicillin plus clarithromycin. The successful eradication depends on a few things. Antibiotic resistance in the local regions or in Singapore is very, very different to the H. pylori antibiotics resistance pattern in India or Japan or Korea. The next thing about successful eradication is patient compliance, the potency of the PPI. So I'll address that later, but the potency of the PPI actually determines how effective your eradication regimen is. And finally, induced antibiotic resistance. This only comes after your failed first-line therapy. The person's innate H. pylori infection will develop resistance. For example, if you treat a patient with PPI plus amoxicillin plus clarithromycin, the person failed this therapy. You know that there's a small increase in amoxicillin resistance, and the person is most likely to be highly resistant to clarithromycin. So the next second-line therapy, you should not use PPI plus clarithromycin again, regardless of what content is inside, because the high resistance pattern. So I've ever seen some primary care doctors use PPI plus clarithromycin plus metronidazole. Later I will show you, but that is probably a very poorly selected regimen for second-line therapy. Some considerations. So it depends on the local resistance, as I mentioned. HP eradication nowadays must be more than 7 days. The reason because there's a rising resistance due to the prevalent use of antibiotics. In this study, these are two studies from Canada and also Korea. Italy and Korea. And it shows that as you increase the duration of antibiotics duration from 7 to 10 days, the eradication rate also increases from 75% to 81%. The same thing with the in the Korean study. As you increases the eradication rate goes up to 92%. So the longer the better. But I think the current standard is always 10 to 14 days. So the next question is for eradication, you should have some armamentarium in your GP clinic. For example, the availability of bismuth, levofloxacin, or tetracyclines. Warn the patient that the antibiotics eradication is not 100%. It's about 95% at best. The H. pylori resides in the mucus layer of the stomach, so it's therefore very hard to kill. So compliance is very important. And potency of acid suppression. So in this study from Changi Hospital, they've shown that in the recent decade, metronidazole resistance is about 48%. Clarithromycin resistance is about 17, almost 20%. Quinolone is about 15%, so all your levofloxacin. Tetracycline 7%, amoxicillin 4%. I did a similar study back in New Zealand. Similarly, you can see 50% metronidazole resistance. So I don't even use metronidazole at all as part of my HP eradication therapy. So in your penicillin allergic patient, I won't even use metronidazole containing agents. So when I was in Senka, I did an audit for 2018 to 2020. This is not randomized, so it's just what the clinic uses, and we're auditing the effectiveness. So 14 days of PPI plus amoxicillin plus clarithromycin gives you a high 80s, not even 90%, high 80s for eradication. The PPI here could be omeprazole, pantoprazole, lansoprazole, or esomeprazole. And I'll come to the differences between these later. You see here metronidazole containing regimen for penicillin allergic patients. 14 days, you only hit 70%. It's less than 3/4 of the patients. So really no point giving PCM because 30% of the time you know you're gonna do second-line therapy and you have a big headache on what to take, what to give. Any business containing regimen gives you 85%, 84% cure rate. And again, any metronidazole containing triple therapy, whether it's PCM or PAM, it gives you a very, very low eradication rate. So this is a study again from Singapore. As you can see, 10 days of triple therapy versus 14 days. 14 days just give you that extra 4 or 5% of eradication rate. And sometimes that makes a little difference because once you eradicate it first time, you don't need to scratch your head and give yourself a headache as to what antibiotics you need to choose for the second line therapy. Remember, metronidazole doesn't really work. So you really have to scratch your head out and try to source tetracycline or levofloxacin for your second line therapy. So if you can treat adequately 14 days in the first exposure, it gives you less worry for the if the patient fails HP eradication therapy. Again, this is a second line therapy. Notice that bismuth containing therapy gives you 82%. Levofloxacin containing, although the numbers very small, 90% cure rate. Okay, so this is the other studies that show 10 days sequential therapy versus triple therapy versus concomitant. There's not much statistical significant differences. But the most important thing is here, again, is compliance and how you manipulate the treatment regimen to increase the cure rate. And remember, metronidazole, very high resistance, clarithromycin, probably one of the important determinants of the successful eradication in a first-line therapy. So in 2011, 2014, the clarithromycin resistance was 17% of all comers. And the 10-day therapy cure rate was still excellent at 90%, more than 90%. So we talked about the antibiotics. Well, let's talk about acid inhibition. So as your stomach pH increases to be more than 5, there's suggestion that the bacteria start to proliferate and they become more sensitive to your amoxicillin and clarithromycin. So the earlier in that 14-day regimen, you can increase the gastric pH to a higher level, the earlier the bactericidal activity starts with your antibiotics. So this is a study with one dose Volsenti. So Volsenti, vonoprazan, which you probably have heard before, a new kind of potassium channel blocker. A 10 milligram dose is equivalent to your 70 milligrams of omeprazole. So this one shows you the potency. Esomeprazole 40 milligrams or rabeprazole 40 milligrams is equivalent to your 60 or 70 milligrams of omeprazole. So when you start to give people triple therapy, I wouldn't give omeprazole 20 BD. I will probably give, you really want to, you probably have to give a higher dose because the better the acid inhibition earlier, the more successful the eradication rate. So pantoprazole, we know some of our clients have pantoprazole because you give to patients with clopidogrel as a prophylaxis. It's actually very weak. So pantoprazole has the same equivalent dose as 5 milligrams of omeprazole or your Zenpro. What does the PCAPs do? Is that the vonoprazan, the potassium competitor acid blocker, even with a single dose, you will achieve maximum inhibition of your acid secretory channels. Whereas your PPI, it takes about 3 or 5 doses before it reaches the maximum inhibition rate. Or sometimes it doesn't. So depending on what PPI, for example, if you use pantoprazole, it probably doesn't never reach the maximum inhibition level. Again, this is another example. A single dose of vonoprazan has a higher acid inhibition rate compared to esomeprazole. So a 20 milligram single dose, 91% of the time you will have a pH more than 5 or more, whereas you gotta do esomeprazole BD before you almost close to the 91% inhibition with a single dose of vonoprazan. So managing active HP infection, I would say first line amoxicillin, clarithromycin plus a very potent PPI for 14 days. So I normally do 14 days. If you have vonoprazan, please use it instead of PPI because it will increase your eradication rate much better. If a patient already on PPI, amoxi, and clarithromycin, the chance of repeating the same regimen to cure the patient is very unlikely because the patient would have developed amoxicillin and clarithromycin resistance already. I mean, not the patient, but the bacteria. So when you consider second-line therapy, please consider potent PPI plus amoxicillin and levofloxacin. Amoxicillin in this case, because the H. pylori doesn't have some so significant of a resistance pattern, so the baseline resistant percentage to amoxicillin is usually around 2 to 5%. So it's actually very low. So what you can consider is use high dose amoxi in the second line, 1 gram TDS plus levo, or you can or you can add in a bismuth. We do have it available in Singapore, so you can add in a bismuth. Consider vonopressin as or a very high dose potent PPI, for example, 40 milligram BD of esomeprazole. Remember, clarithromycin is an inhibitor of cytochrome P3A4. PPI is metabolized in cytochrome 3A4. So when you give PPI with clarithromycin, the clarithromycin will increase your PPI drug levels. So the other thing also happens. The PPI will also inhibit clarithromycin. So the more potent your PPI, the more likely your clarithromycin level will come up, and your PPI level will come up as well. Okay, so let's talk about GastroClear. GastroClear is a one of those common screening tests instead of gastroscopy that's been developed by a Singapore company that measures 12 microRNAs, and that is a good test to screen, to exclude patients, to avoid them from having screening gastroscopies. Now, the study have shown that the area under the curve, or the receiver operator curve, is very, very high compared to other cancer markers. What it is suggested is that it should be used in patient age more than 40, with or without any risk factors such as family history of stomach cancer, past history of H. pylori, chronic gastritis, or any lifestyle issues. My personal preference is that if the person has already got high risk, I would go ahead with gastroscopy. I would bypass GastroClear. I will come to the reasons later. This test, it is then split into 3 categories: low, intermediate, and high. And in their website, they suggest to repeat scope in 1 or 2 years if it's low. Consider gastroscopy if it's intermediate or high. So this thing has a higher negative predictive value, but it's not very sensitive and specific to target early gastric cancer. So in asymptomatic population, the sensitivity of this is 80 to 82%, specificity of 88 to 90%. So if you have a symptomatic high-risk individual, the sensitivity actually it increases, but your specificity drops. So in your patient's average risk, there are false negative rates. So the false negative rate for GastroClear is 18%, and false positive is 12%. However, if you go into a higher risk individual, those with family history, those with smoker, older age, then the false positive rate can go up. And indeed, I've seen a lot of patients who have high risk for GastroClear. You put a scope in, you can't really see much. There's no cancers. In the original study where they did it, published in Gut, the Singapore cohort actually was small in number, so they included a number of Korean cohort. In the Korean cohort, they have about 25-30% of active H. pylori infection. So because of that, the GastroClear, when they set out to market as a test, the GastroClear actually cannot differentiate whether someone has active H. pylori infection. So sometimes when you have active H. pylori infection, the GastroClear result will come out as high risk. So you just have to be cognizant, make sure you understand how to interpret the test. Of course, if the GastroClear test is low risk, means there's nothing wrong. But when it's medium or intermediate risk or high risk, you have to think about a lot of whether there's higher false positives. So the causes of false positive GastroClear are the issues, of course, with the non-gastric cancers, and they can cause cross-reactivity, active H.Pylori, presence of intestinal metaplasia or chronic gastritis, which I'll talk about later, or any kind of gastric inflammation can push up the score. So your GastroClear can be false positive. Precancerous lesion like intestinal metaplasia can increase your risk of having a high positive, high cutoff. Okay, let's talk about intestinal metaplasia. It is quite common in in Chinese. So in Singapore, the prevalence is not low among the Chinese population, and if you're from East Asia, the incidence is higher as well. Gastrointestinal metaplasia is a precancerous lesion where your stomach lining is replaced by intestinal type epithelium due to chronic inflammation. What are the causes? Untreated H. pylori infection, autoimmune gastritis like pernicious anemia, atrophic gastritis, smoking, the diet low in fiber or high salt intake, genetics, and older age. So this is a picture of intestinal metaplasia. When you do a gastroscopy and you filter change to a blue light, you can see this thing and you can tell immediately this is an intestinal metaplasia. How does it progress? So normally we'll have normal stomach lining becomes chronic gastritis. As the inflammation continues, the lining of the stomach gets replaced with intestinal-like cells. And then the intestinal metaplasia can be staged into 4 different stages. The higher the stages, the higher the risk of developing dysplasia. After it becomes dysplastic, then the risk of gastric cancer goes up. What are the grading or risk of gastric cancer progression? So we, as a gastroenterologist, will stage them into different stages, what we call OGIM, stage 1, 2, or 3, 4. Stage 3 or 4 have higher risk of progressing into cancer per year. And therefore, in anyone with intestinal metaplasia, they will need surveillance gastroscopies to make sure their risk is defined by the stage, OGIM stage, and they get advice on when is your next surveillance scans. Okay, I think this is okay. So the OGIM stands for operative link gastric intestinal metaplasia. Okay, this is the study that's from our Singapore Gastric Cancer Epidemiology Study, GSEP study, that was published in GUT. And as you can see, when you stage them into different stages, patients at baseline, year 3, and year 5, a proportion of patients do progress to accelerated and higher stages as time passes. And these are determined by several things. For example, the nature of the intestinal metaplasia, whether they smoke, whether they are older, whether they have a family history of stomach cancer. Okay, thank you very much.
So the question is, right, what is okay, are there any lifestyle or dietary changes that we should make to help with the H. pylori infections or liver lesions?
My recommendation is when you live in a household with other people with H. pylori, you must have common utensils. So you don't share the same chopsticks, share the same drinks or straw, share the toothbrush. If you're intimate partners, for example, spouse, kissing and saliva exposure over a long period of time can increase your risk.
Thank you. Thank you for sharing. And also thank you, Dr. Johns, for today, because any questions, right? If let's say there's time limit today, you can actually still look for Dr. John from Gastroenterology's Richmond Gastroenterology Center. Yeah. Thank you, Dr. John, for today.